We'll begin the session. Thank you very much. My name is Sterling Bryan. I'm the Chief Scientific Officer at Michael Smith Health Research BC and the nominated principal applicant for the BC Support Unit. And delighted to welcome you to this parallel session, which is on learning health systems in British Columbia, an introduction and an overview. So learning health systems, I think, is language that we're all now familiar with, or at least many of us are becoming familiar with. But probably when we use the language of learning health systems, it doesn't always necessarily resonate, or sometimes I think we're using the language in different ways. So I think this is an opportunity to have that conversation about what we mean by learning health systems, and actually what do we want to achieve with this notion of learning health systems. So we're going to have a presentation, and then we'll have an opportunity for discussion. So please feel free to put your questions in the app, or you can come and articulate your question at the microphone. We have three speakers. We're going to start with Waqar Mughal, who is he's our Director of Data within Health Research BC. We've got Linda Lee, who is our Scientific Director in the BC Support Unit, and we've got Ross Duncan, who is a Learning Health System Data Analyst within the BC Support Unit. Or at least I got that one right. Okay, good. Okay, so without further ado, I'll pass over to Waqar.
I'll speak up here. Thank you all for coming. I want to begin with land acknowledgement. I am very cognizant of the fact that we are all visitors here, uninvited guests, and I do want to recognize that we're holding this event today on the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And as a provincial organization, we do work across the province, and so I wanted to take an opportunity to recognize some of those other nations that where we do perform our work: the Nklawak, Kapma, the Silix nations, the Clay Dene, the Nuchanuluth, and the Kwakwaka'wakw on the island. I will hand this over. It'll begin with Linda.
Good afternoon, everyone, and welcome everyone who's joining online. So when it comes to learning health system, I'm also a learner of the learning health system, so I have this privilege to share with you some of the perspective of how this is like. As a health researcher and a physiotherapist by background, it is really an exciting time for research. It used to be that research and care delivery are two separate worlds. They don't really talk to each other. From time to time, some information is go from one way, mostly from researchers to practice, to care delivery. But with the last, let's say, about 20 years of knowledge translation and exchange, knowledge mobilization is the term we have it right now. The space for research and care delivery is coming a little bit closer, and you can see that in the second line that there is a dialogue between researchers and practitioners where knowledge is sharing back and forth with research knowledge informing practice and practice informing research. It's good, it's better, but it still takes a long, long time. So the encouraging thing is that now we are actually coming to the point that research and practice are mature enough, as two entities and starting to have some overlaps. And this sweet spot is what we call learning health system. So how do we see learning health system? I'm sure some of you have seen some of the models. Some are a little bit complex, some are a little bit simpler. We choose to use this one because I think it's something that even me as a novice in learning health system can understand. So at the core of it, learning health system, it includes patients, partners, and the learning community. So with healthcare organization, with policymakers. So what goes around these really important individuals are three different steps in a perpetual cycle. So you have data generated from real-life practice. You have the data, and this data is being used to generate new knowledge, and the knowledge can inform practice. So what it really happens is that when an organization is ready to change, you collect data from your real-life clinical practice. You invest in expertise to analyze the data in order to generate new knowledge, and that knowledge is applied into practice right away. So now, we heard that in the last session that knowledge is really a part, this knowledge needs relationships. So the patients, research partners, having this close relationship is fundamental in order for this perpetual cycle to function properly, so that practice generate data, data generate knowledge, and knowledge goes back to inform practice, and it goes on and on. Now, in order for this perpetual cycle to work well, we need to have some fundamental enablers. So what you see at the bottom are some of the critical components. We need to have enablers from the social aspect. We need to have scientific expertise. We need to have the technological readiness, the infrastructure in order to collect, store, analyze, and visualize these data. We need to have the policy to be there for to enable this process to start and continue. We need to have the legal and ethical component to be in place. So what are some of the key enablers for learning health system? There are 4 things that I think we can sort of sum it up. Part of it is that we need to have the workforce. We need to have the skilled workers who know how to do the LHS or learning health system work. There's a recent article that was published in the US that looked at what are the competencies of learning health system, and they identify 7 different domains and 33 different competencies. And it's not just competencies for individual workers, but we're talking about at the system level, what needs to be in place for the researchers, what kind of qualities that they need to have, and methodological skills that need to have, and the healthcare practitioners, what kind of skills that they need to have in order to contribute meaningfully in this learning health system, and also at the patient perspective, what sorts of skills and expertise that individuals need to bring to the table in order to enable some of the conversation and some of the work that's required for learning health system to function. Second thing is that we need organizational culture. We need a supportive organizational culture. So first of all, the organization need to champion for learning. So when we're talking about learning, it's not just the attitude of lifetime learning, a lifetime learner, which we know really well, and some of the health professionals and practitioners in the audience know about this term lifetime learning really well. But when we talk about learning in a learning health system, we're talking about the skills and the willingness to continuously collecting data, you're analyzing data, you're using data to generate knowledge, and you're applying the knowledge in practice. And we need to have that culture there for a learning health system to be successful. Third thing as an enabler is that we need to have that infrastructure. So we'll need to have the data system to be in place, to collect and store, and the informatic technology and the resources that's in place to be able to analyze and visualize data. And the last piece is that we need to have the organizational investment in the learning health system work, and I think that is one of the most important, critical component for it to be successful. So organizations need to have policies that incentivize people to do work in learning health system. As I mentioned earlier, that the whole process of collecting data, analyzing data, and using the knowledge to change practice, that's a lot of work. And so having the proper incentive is critical for it to be successful. Second thing around investment is that the organization need to have the capacity and willingness to invest in research itself. Again, it comes back to the capability and the willingness to continuously collect, analyze, and using data to generate knowledge and put it back into practice and does not stop there. So in order for it to be truly successful, I would suggest that we need to consider in learning health system really support the people who are embedded as researchers within the system so that they can actually be embedded in the research, asking and answering important questions, and to be able to guide the research process and the knowledge mobilization activity as well. Now, so that all sounds good, but it comes back to reality. And this is a graphic that was from Maureen Smith, who is one of the patient partners who does a lot of work in learning health system in Ontario. So we talk about the importance of having all the partners together, the patient caregivers and the citizens at large, the researchers and the health system partners. But in reality, right now, those three parties are not really at an equal playing field. It's a wobbly stool. So in order for learning health system to work, and I think part of the work that the BC Support Unit is investing in is to look at strategies of how to make sure that we can balance some of the voices and the contributions and the perspective from all of these parties so that we can have a stable platform that for the learning health system to work and thrive. Yeah. Okay. So I think that there are a few pieces that we would like you to consider in this session around that are critical to learning health systems, and there are three components that we'd like to point out. These three components are really, okay, that's interesting. Okay, these three components are really items that if you look into any successful learning health system, you will be able to identify them. And that distinguishes it from other types of improvement practices. So namely, the ongoing data evidence collection, interpretation, and application to practice, number one. Number two, patient engagement. And number three is really having a diverse and multi-partner workforce, having a true learning health system team. So in the next part of the presentation, you're going to hear two case studies on successful learning health systems, focusing on these three components as an example. So with that, I'm going to pass on to Ross Duncan to share the first case studies.
Just give me a moment to orient myself. Thank you. Okay, good afternoon, everyone. My name is Ross Duncan. I am a learning health systems data analyst, and I have a confession. After 3 years, I'm still not entirely sure what all those words in combination mean. But hopefully I am in good company today, and I think I picked up a few things along the way. If I could try and describe what we're trying to do with LHS, it's that we've kind of figured out that learning, a bit like life, the journey is as important as the destination, particularly because the journey determines where you end up. And so what we're trying to do with LHS is try to make sure we have the right people moving together, doing the right things at the right time to make sure we end up in the correct place. Our journey today is not to the Swiss Alps, as the title might suggest, but rather here in beautiful British Columbia. We're going to be talking about the HEIDI Concordance Program, and what HEIDI means is HealthLink BC Emergency Eye Doctor in Assistance, so another lovely health system acronym. But this comes from the HealthLink or 811 telephone triage and advice line, which some of you may be aware of, and up until 2020 and the COVID pandemic, this was staffed exclusively by nurses. But then, of course, during the pandemic, we were trying to flatten the curve, and while we don't like ED wait times at the best of times, it's a particularly bad idea to have large numbers of people grouped indoors waiting for extended periods of time when we don't know quite what's going to happen with things like spread. But in addition to that, we also noticed that because we were telling a lot of people to stay at home, they weren't accessing care in the way that they normally would, and they had a lot more questions than they normally would. And all of these sort of combined to push a lot of pressure onto the HealthLink system and had an increased need for diverting people away from the ED whenever possible. So to this end, the HIDE program was created by HealthLink BC by hiring emergency physicians to act as virtual physicians on the phone or on Zoom or similar to add an additional layer of advice for particularly tricky calls. Okay. And this is an example of what I would call a learning community around the system was centered. So the health system sponsor was actually the executive director, Sandra Sundhu, of HealthLink BC. And she was working closely with the digital emergency medicine team led by Dr. Kendall Ho at UBC, and they were already sort of in touch. But what they realized is, Kendall, you're an emergency physician who works in virtual care, and I'm running HealthLink. Why don't we get together and run a program that evaluates the rollout of this novel program into British Columbia? And so that's very much what they did. And to do that, the teams contacted the support unit and said, how can we go about doing this? We helped get them onto the health data platform. And then we realized, hey, we have people from all these different organizations who are all interested in working together on this project. So something that this project did that others I hadn't seen due to this point but was quite interesting is we actually gathered people from all these different organizations, sat down and said, have we covered everyone who should be involved in this organization? Is there anyone that we're missing? What are the rules under which we should conduct ourselves? How do we choose what research we proceed with? How do we fund that research? And we actually explicitly sat down and sort of hashed these things out as an organization. There's a terms of reference for this and everything. And I think it was important to actually get a sense of ourselves as a community and what our shared goals were and what we were working toward. So this is the general community, and from this spun off what we called writing groups. So people from this community who were interested in specific aspects of the HIDE evaluation could join in on those projects. And I had the privilege to be involved in a project around what we called concordance. So here, what that really means is when the patient received advice from a virtual physician, did they end up using the service suggested by that virtual physician within 1 week of the call? Unfortunately, further out from that, it's harder to tell whether or not it has to do with the reason for the call or something else. But some interesting things around here from a patient-oriented perspective. A lot of language in the past around physician advice would use things like adherence or compliance, which we understand can, one, be kind of hostile, and also sort of implies that the doctor is always right, and if the patient is not doing what the doctor said, then the patient is doing something wrong. But an interesting experience we had working with emergency physicians in this is it was actually the emergency physicians who pointed out to us repeatedly that patients often had a valid reason for opting for a different plan, if that is what they ended up doing. And so they steered us, along with our patient partners, towards this conception of mutual agreement between patient and clinician on a course of action. And so that's an example of how having both clinicians and patients at the table can affect the questions that you ask and the framing that you use. Okay. So don't worry, I'll provide a little more information on the right-hand corner in the moment, but I think the important thing to point out here at the top, if that'll show up, is the critical components of an LHS here, or the things that we like to talk about, is that there was patient engagement, there was a patient partner, a person with, I guess what we would say, lived-in living experience. That was provided through the Emergency Medicine Network, who had an ongoing patient council. We had a multi-partner LHS team, so we had clinicians, we had patients, we had researchers, and critically, and sometimes the missing piece, is we had a health system decision maker as our sponsor and our champion in working on this. And we'll get into the ongoing cycles and things like that, but if you haven't seen one of these things before, the idea in the cycle is that you see what's happening in practice, so what is actually happening out there with HealthLink and the calls. Someone would call into 811, they'd initially get triaged to a nurse. If the nurse could handle that on their own and felt comfortable, then that exited. But if they spoke to a doctor, then that was counted as HIDE advice, and that practice was fed into data that we then analyzed. But it was during the data to knowledge step that we realized we'd kind of done something incomplete. So we'd just used numbers, quantitative analysis, to basically look and see What sort of patterns can we see among the people who call into HealthLink? Are they disproportionately rural or urban, or are different people from different categories more likely to follow different categories of advice? And it turns out that yes, they are. Patterns of responding to advice are quite different, whether you're a caller from a rural or an urban area. We noticed there seems to be issues with accessing family physicians. We noticed that people calling for reasons that had to do with gynecological or postpartum issues seemed to behave differently than other people. But what we realized at this part of the step is that we didn't know why any of that was happening. And so that was the part where we had to stop and say, oh, we need more information, because if we're actually going to take this knowledge and convert it to something that can inform practice, we need to know more. So on that left-hand screen there, I can't quite read it, but we should have the initial things that you could see where we're looking for those concordant stats, yes. We're looking for safety, yes. We've been doing that since the outset. But what we want to do to complete this cycle and actually inform practice is actually go out and do qualitative interviews with patients to learn their experiences, talk to them directly. When you are receiving this advice, what are the considerations that you are making? What barriers may you face, and what could we do to make that easier? And similarly, clinicians have their own experiences on this that we should talk to. Basically, how can they change or tailor their advice? What options are available to change these aspects? And so our hope is that by adding these additional forms of information, we can then translate that knowledge to practice. And ideally, to circle back to Amy's keynote this morning, we can bridge that sort of science practice gap, hopefully by feeding this information directly back to HealthLink BC and the physicians who are involved in delivering the care. So thank you for the opportunity to talk about that with you. And I guess back to Waqar.
Thanks, Ross. So I'll present our second case study. So Ross was deeply involved in the first case study. I'll be going over a published paper that speaks about learning health systems, and it's so I won't be able to go into as much depth, but I do want to convey some of the crucial components. So this case study is about a preventative health learning health system. It's based out of Ontario. It's called My Heart Fitness. It's run by a cardiovascular team. It consists of a digital learning platform that aims to improve health knowledge and lifestyle management. So looking at both post-operative rehab, but also preventative therapy as well. The project included a multidisciplinary care team and a large project team. There was medical care professionals involved in the care team, physicians, cardiologists, kinesiologists, but also on the larger project team, it included nurse practitioners, internists, research scientists, medical education folks, research ethics, health informatics, and health policy. Also had individuals contributing to the team. So it was a very large group, and it involved the platform allowed for a dynamic, personalized lifestyle learning journey addressing many different patient needs. It was intended to be an easy-to-understand guide to help support improvement in health practices, understanding risk factors, and so on. So I'll share the process here. So it began with a referral to the My Heart Fitness program and a baseline health assessment. The goal was to increase the activity level and knowledge and awareness of the risk associated with cardiovascular health. So the patients completed their assessment. The assessment was reviewed by the project team, or the treatment team, and a plan was developed. The plan was provided to the patient, and then they entered the circle. So the cycles of work involved 11 telemedicine appointments held almost equidistant across the course of 6 months. And within those periods of time, patients provided information between each visit back to the team that gave them their experience. It talked about their activity level, and it gave all of this information was provided through the digital health platform. These data were reviewed and discussed by the project team in between the meetings for each patient. And the appointments themselves provided the team an opportunity to talk to the patient about their experience, about the learnings that they had, any challenges or new barriers that they encountered, any new symptoms, lifestyle goals, safety issues, and evaluate selective risk factors. And based on that experience, the care team was able to modify their treatment plan, modify the goals for the patient, and improve the experience for the patient in each cycle. So in summary, the goals, the patient goals, educational curriculum, action plans, medical decision-making processes were iteratively reviewed and discussed, and the patient plan was customized based on the new knowledge obtained and reviewed in each cycle. So in terms of the outcomes for this particular learning health system, there were improvements seen in the physical activity of patients, especially those with lower levels of initial reported activity, a high level of engagement in the process. People attended these sessions, even though they were telemedicine, there was a high rate of compliance with that. And then there was also a very positive user experience with the whole process. In terms of the checklist that we have, there we are. In terms of the checklist that we have, the project included multiple cycles of activity, data collection, learning, etc. And the project team has many different roles within its own membership. However, the patient engagement was a little lacking. The patients were involved. They were there were the groups that were receiving care and providing data, but there were no mention of patients on the project team itself. And so in that way, it highlights how this example and also the previous examples that we have still a journey left in terms of developing learning health systems. So with that, I will hand it over to Sterling to help with a discussion.
Great. Well, thank you very much indeed. Good. So we have 30 minutes and 32 seconds for conversation. So please feel free to put a question in the chat on the app, or you can come in to the microphone. I'm going to take one question from the app, but then please I'll come to the microphone next, because the question in the app, I'm not going to ask you to name yourself, the person who put this in, but this was actually the question that I was going to ask. So I was intrigued, and I wanted to tick the thumbs up, but it's been disabled because I'm the moderator of this session. So so I don't have the opportunity, but actually I do have the opportunity, like, I suppose, because I can actually ask the question. Anyway, the question is, how is learning health systems different from quality improvement? And how is it similar?
I know how to say.
So I'm going to ask Linda to answer this question first.
I'm asking the novice
Is
in
that
learning
okay?
health system. I think there are a lot of similarities. Let me just acknowledge it first. Learning health system is about improving the quality of practice. So there is overlap between, the learning health system itself and the quality improvement. But I think with the learning health system, the three components, the checklist that Waqar was talking about, that, it's not only just, collecting the data and analyze and so on, but it's the patient engagement piece that need to be front and center. And also having the capacity, the workforce to be able to do the work that makes it a functional system. And I would also add that, quality improvement as a hallmark of a learning health system, the methodological rigor, knowing how to ask and answer a question that is relevant to practice is essential, and that's actually two of the domains on the competencies for learning health systems. So I think those are some of the items that I think separate learning health system from what we usually know as quality improvement or improvement practices.
Okay, thanks very much. I get the impression Waqar wants to give us an answer. I think you just speak into it and it'll...
Okay. So thank you, Linda. And I probably want to talk to some of the similarities maybe, because I had a chance to speak to the Patient Partner Network yesterday. Thank you very much for giving me time to talk. The total quality improvement was brought up as a model that is very similar in the sense that it also has repeated cycles. And I think there are a lot of parallels there. One of the things that I appreciate about how learning health systems is described in the literature is that it speaks to some of the uniqueness that is present inside of the health system, as opposed to any other industry, manufacturing or other types of service delivery, in the sense that the amount of data that the health system collects and captures in the work that it does on a day-to-day basis is a lot. And the level at which it's utilized is fairly low, given how much data that they collect. And I think the technology component and the scientific component, Foundations for Learning Health Systems, recognizes that and speaks directly to that. And I think that's one of the pieces that's really unique for learning health systems, given that it's a quality improvement practice designed just for the health system. So that's one of the other distinguishing factors, I think.
Okay, thanks very much.
Yeah.
Ross, briefly.
Okay, briefly. One thing I would say is that quality improvement, to me, is just a form of learning. So it can fall under the learning health systems framework quite well. The other thing I would say is that the LHS, it's not just about the cycle. There's a whole set of principles and values that are built into LHS that I'm not sure necessarily falls into a quality improvement framework. So things like an LHS should be person-centered, it should be transparent, it should have bottom-up perspectives. Those are meant to be built into the way that that process is engaged in a way that I don't think is necessarily clear when you just say quality improvement.
Okay, thank you very much indeed. So we'll go to the audience, please.
Thanks for the presentation. I just want to go back to the way you're describing and framing learning health system. The previous panel we just heard talked about how things have to be relatively embedded in their community. And if we use the Indigenous example, would they talk about learning health system, or would talk about knowledge generation in a different way? You know, coming from the elders and then dispersed in their systems. So maybe that's a next evolution for what you're doing with the learning health system, because I think the way you described it, and I would use the Heidi as an example. We heard that there's not a lot of trust, especially when there's no relationships established. So I think that it would be difficult to have a Heidi-type physician call into a community that there's no relationship to, and there's not the trust. And so for me, that's just an example of how I think there would need to be evolution to go in and say, you know, do you think it would be good to have this type of knowledge supported in your community just in time as you were trying to do? How do you think it would be done? And how could we support it centrally through this type of work? So that's just an example. So I'm not being critical, because of course I think it's very good for all of us to actually go through those sorts of things, but I think it might look different in different areas. So I just wanted to kind of join those two panels.
Great, thank you very much. I think that's a really important point that you've made, and I think something that we want to reflect on as we take forward the work both on the learning health systems piece, but also working in partnership with communities, Indigenous communities in particular. And we don't want to assume that this model and that this language is the appropriate language to use in that context. So thank you very much for that. I think we have, Larry came and stole the mic, so I think, all right.
For my benefit,
Kent,
Sterling, for my benefit.
Please go ahead.
Yeah, it's just lovely to see so many familiar faces there on stage since the embryonic days of the founding of the support unit and beyond. But my question today relates to a problem that patient-oriented research also seems to continue having, and that is that the reciprocally beneficial relationship with clinical education and interdisciplinary healthcare training is not consistently recognized. I mean, I did hear some very speedy mentions of medical education, and there was a very nice graphic in the cyclical graphic that you showed here earlier of like an instructor and an audience. But where does where does the learning health system and interdisciplinary clinical education complement each other, and how can we more consistently embed them as a considered element of one another?
Great, thank you very much, Kent. I think we have one person on the panel who is clinically educated, and therefore I'm going to go to that person to give an initial response to that, if that's okay.
Thank you. And thanks, Ken, for the question. Great to see you as well. You know, I think the learning health system, you know, as we are describing it today, is still at the early stage of evolution. Even learning health system has probably about 13, 15 years of literature if you go back to how it's being used and how it's being developed. But you got to start somewhere, right? So the way that, you know, the entry point for learning health system is usually the system itself wanted to change. So it looks like the questions driven by the health authority, by the organization itself, and it looks like the learning is within the organization. But I would agree with the individual that you asking the question that I think, you know, there needs to be iterative process, and that learning and student education will need to be embedded, you know, into this process. So within a learning health system, when you're looking at the core, who are the people, the patient, the partners, the practitioners, and of course the trainees are part of, you know, this process where, you know, when you have the data collected in practice and being generated into knowledge and, you know, goes back into you having this knowledge translate back into practice. It filters, you know, through clinical education in the clinic and in the classroom as well. So we got to start somewhere. We're not there yet, but, you know, I envision that if we're doing it right, it will be part of normal way of doing business in clinical education.
Let's hope so, and I think the takeaway from that for any other clinical educators that might be in our audiences of various kinds is just to keep showing up and talking about the reciprocally beneficial relationship between the learning health system and clinical education.
Great.
Thank you, Linda.
Thanks very much, Ken. Yeah, absolutely. We need to keep that in mind. Okay, I'm going to go, if Ross could get his microphone back, because I think this question is probably one that...
I'll trade it for your time.
I'm going to go with a question that I think this is a really interesting and important one to reflect on. So I'm going to ask Ross to reflect on this one to start with, if that's okay. Are there concerns that data are interpreted and implemented too quickly, potentially missing long-term impacts and thus potentially increasing risks to patients?
Yes.
Okay.
I mean, to not be as glib about it, I mean, that's always a concern. I think particularly with the pandemic things like Heidi, I think you can see, we started doing a project, we realized about 2/3 of the way through, we didn't have all of the relevant information to actually make a change. So in that case, we kind of didn't get as far as we wanted to because we raced ahead rather than properly considering all we'd need to make the change. But I mean, you can imagine some situations where you rush ahead with an intervention and you're all gung-ho about it, and then it turns out it was the wrong thing to do. I think someone who has more experience balancing these things can probably speak better to it, but what I would say as a hope in future is with things like LHS, there should at least be people continuously keeping an eye on concerns by including both clinicians and patients and administrators in the conversation about what we're looking at and what we're testing. We hopefully catch some of these things earlier or preclude them from happening in the first place. And then also by really I think part of what LHS should do is make you really think about what you're trying to capture, because it needs to be something you're capturing over time as well. And actually sitting down and thinking, is this something that is worth tracking, and what does it mean to track that properly, rather than just rushing to publication, is probably a better system. So that's what I think off the top of my head.
Great. That's a very considered response, and I think a very appropriate response. I use the language of horses for courses. And I think in an LHS context, it's an important, so some horses run really well at some courses, but not all horses run well at a particular course. And I think, like, so what I'm trying to say in a roundabout sort of way is that I think that sometimes we need to take time because before we actually make a change in order to like understand that the benefit really is there. And then at other times, we can see that benefit quickly, and we should be making that change quickly. But we shouldn't necessarily impose the same period of time to make the change with all changes that we want to make. So horses for courses in the context of learning health systems, perhaps. Okay, let's move on. Waqar. How can we navigate learning health systems given the structures we have in place in research, in the health system, and government? The sort of pressures that we have in the system, how can we expect people to embrace this sort of model? Thank you. Whoever put that question in the chat, I like that one as well.
Yes, thank you. Thank you. I'll come talk to you later. I think the health system has had many years of dealing with change, trying to go through change with having not enough resources to deliver the services that it wants to deliver. I think it will be very helpful if we can get everybody onto the same page. One of the things that I think will help is if we view learning health systems not as an initiative or a project or a pilot, because we all know we don't need more pilots, but rather as an approach to managing care, managing a program, managing a service, to take it as a new method for doing work that you have to do already, and with the hope of improving the outcomes for not just the patients and their families, but also the experiences of them during the care delivery process, as well as the experience of the teams that have to deliver that care. So to actually bridge all three groups isn't going to be a very easy effort. The one nice thing, though, that we're beginning to identify is that learning health systems can be established at almost every level of the system. So the most obvious one is the ones that we described, the ones where a care team is working with patients in a patient group. You can have those systems set up with a number of different groups within one program, and that leader can have multiple systems reporting in on data and having that looked at the program level. And then there can be also consistent measures across multiple different programs that a senior leader can monitor, VP of medicine, for example, that they could have that can allow them to understand the benefits of the services and the challenges that the different services are experiencing. So right away, it can become relevant to the health system quite quickly and the leaders within that within an organization. That in turn should also be beneficial or of interest to the ministry, because that can be a model to implement change, to manage change at all different levels and implement it in the different contexts in which the care is delivered across the province.
Great. Okay, thank you very much indeed. I think we have a question from the floor.
Thank you for explaining the learning health system. It's like a clearer concept to me now. So as a trainee, I would like to ask, like, what role do you think trainee can play in initiate something about learning health system? Will they have the capacity to initiate a project of learning health system? Because in the cycle that you just showed, it seems that it's like it needs to be initiated from a higher level or leadership level. Can trainee have the capacity to do it?
Great.
Thank you.
Thanks very much. So did you write the question, how can we incorporate trainees into learning health system practices? No, all right, okay, excellent. Well, you sort of voted that one up as well. Linda.
Yeah, no, that's a really good question, you know. So as I mentioned earlier, you know, the learning health system process, you know, that cycle starts when an organization identifies that they want to change. So oftentimes you need to have, you know, that organizational initiation and buy-in for the process to start. Now, a lot of people, you know, are involved, you know, in a learning health system work, and I think, you know, as the trainee, in terms of opportunities to start your project, it may, you may, have an opportunity if you're working with a team, with a supervisor who is working with the learning health system, within a learning health system, or if your supervisor is an embedded scientist within a learning health system, then you may have an opportunity to identify, a project that is doable within the training period if you're a master's or PhD student. But if you are working outside of the system and thinking to start a project as part of your training, that may be a little bit more challenging. However, one more thing is that we talk about the need of the workforce for a learning health system. We need people who have skills in system science, in informatics, in implementation science, in implementation ethics and research ethics. All of these areas need really highly skilled workers. And, as a trainee, lots of opportunities to get training and get established with those skills to contribute and work in a learning health system.
Great, thank you very much. We've got a question that speaks to the examples that we used. So it says that the example projects seem to have a strong digital health angle. Is implementation of digital health tools especially amenable to learning health systems or not?
I think it's more an artifact of the timing on this, and that it was a situation amenable to the development of virtual tools because it was under pandemic conditions. So we really only started, I only really started working on learning health systems in the last 3 years or so, and we know how those years have gone. So that was what the emergency medicine folks were able to do, and because it was a novel project during that time period, everything was sort of ideally set up for that cycle to be initiated. I imagine as we move to more of a new normal, we'll probably see more in-person things like that.
Okay.
That said, so that's all very true. That said, we have more technology available to us now than we ever had. And so I think that digital tools and digital health will make it easier. It has the opportunity to make it easier to collect information, collect experiences, but it's not necessarily that it won't progress without that. I think that there's ways that we can gather information, gather experience that don't rely on digital tools or the delivery of digital health or virtual health. I think a lot of these things, a lot of these examples, came from experiences in delivering in-person care. So I think all of it, I think we'll progress no matter what.
Great, thanks very much. So I've got a question that I'm going to ask now, but before I do that, I'm just going to warn one person in the audience. The first person who ever used the term learning health systems in a conversation with me is actually in the room now. I think I'm looking at Kim McGrail, am I? Okay. So I'm going to ask Kim to give a comment, but first of all, I will just, if you want to get some thoughts together, but I'm going to ask this question first, and then we'll go to Kim, who will give a perspective on where we are with learning health systems in BC at the moment. Thank you very much for agreeing to do that, Kim. How do you foresee patients being involved in more collaborative roles in relation to learning health systems?
Well, I asked that question yesterday. So as I mentioned earlier, I had a chance to speak with the patient partner network that we have with the support unit. And I think we're going to be working on that. That was the intent, is for us to discover ways in which we can do that work together better. How can we engage patients to make the work that we're trying to do better and more informed and more relevant to the patient groups that we want to eventually help. So I think that that's a question yet to be answered. But Ross has something to say.
Well, I guess I just have what is maybe an example of something I've seen done with this, and I think it depends on the kind of engagement that you're doing. And I would imagine it's around communities of interest. The issue with learning cycles is that it's going to be over a prolonged period of time, because you're going to need to do multiple cycles, and that's going to take years. So for patient partners to be engaged meaningfully, they need to be there fairly long term. And I know the Emergency Medicine Network, rather than engaging patients ad hoc for projects, they recruited a patient council of about 10 people who meet quarterly and discuss issues in emergency medicine, and then bring that to the emergency medicine board and basically suggest projects on an ongoing basis. So that's one way that I think you may be able to do that.
Great, thanks. And I think we've heard conversations around using the language of patient-oriented learning health systems. And I actually think that maybe we should be talking much more fully about that as the model that we're trying to move forward to really make sure that the patient is at the center. So the microphone is free, Kim, if you wish to. The microphone is just here. Thank you. Sorry to put you on the spot, Kim, but...
So just, do you want me to just say something about this current state of?
Yeah, where are we with learning health systems? You've been someone who's been advocating for learning health systems in British Columbia since probably, I don't know, was it 96? No?
Was I even born then, Sterling? I don't know. So maybe it would be useful to say just a couple words about why I was attracted to the idea of learning health systems. Now, the conversation around this has changed quite a lot over time, with Matt Meneer's publication, with others, and your kind of work in this area. So I was working with Chuck Friedman at the time. I became aware of him and looked at his work and really was attracted to it for a number of reasons. So one, learning health systems really, and you've talked about a lot of this stuff, learning health systems are really trying to take things to scale. We get out of this idea of doing small, not connected, not really necessarily as robust as it could be projects. And instead kind of getting something that is systematized, that can function at multiple scales. So we think about learning health systems, I think a lot of what you've been describing are clinical areas, but some more local and some provincial. So those are different scales, which is really important. But in Chuck's view, they could go anywhere from the ward up to the globe, really. And the idea is that they work the same no matter what scale you're talking about. The other things that really attracted me was that the learning community around learning health systems is really fundamentally important to him. And the community that Chuck Friedman always talked about was one that was open, transparent, low barrier to entry, and inclusive. And so part of, I guess, what I would observe about learning health systems in BC is, my gosh, it's amazing. Like what you're describing today are things that I didn't actually know had been going on, and it's amazing. You've really adopted, I can see the principles being adopted. It's really fantastic to see, so that's good. I agree with you too, Sterling, that we could be talking about patient-oriented learning health systems, but I actually think the real win will be when they are inclusive of patients, members of the public, family members, without us having to add that label to it. Like, that'll be the victory. So amazing progress. I'd love to revisit this conversation to hear more in a year or two and see how much further we can get.
Great. Thank you very much indeed, Kim. So we are 1 minute and 33 seconds to the break. So I'm going to ask each of our panel members to speak for 10 seconds max and give us an inspirational message to leave on.
It's all about the journey.
And I'll take on Kim's message that, I think patients, how their involvement is going to look like in learning health system is going to look very differently in the next 5-10 years.
I firmly believe with all of my being that we have the capability of doing this in our system. I really, really do.
Great. Great. Well, I'll ask you to put your hands together and thank our panel. Thank you very much indeed. And now you have a coffee break. I mean, it's really a tea break. I think it should be a tea break, but it actually is stated as a coffee break before the next session. Thank you.